Hi, everybody. Thank you so much for joining me today for what I think is a really important conversation about diagnosing dementia, why it matters, how it's done, and how it can help. Before I start, I just want to acknowledge and make it clear that I wrote this talk for non-professional audiences. So I know many of you who are listening are caregivers, family members, but I've also seen that some of you who have registered are doctors, nurses, nurse practitioners, physician assistants, social workers, and others. So welcome to you as well. As a side note to the professionals, if you're interested in more information about professional training regarding dementia, you can contact Catholic Charities for my contact information for more information about that training. So thanks for being here today. Just having some difficulty advancing slides. Here we go. I want to express first my gratitude and appreciation to the sponsors of this presentation, including the U.S. Administration on Community Living, Catholic Charities Hawaii, and Hale Ku'ike, also of Hawaii. So thank you for the invitation to speak today. Here's what I'm going to be covering. I'm going to start by talking about the importance of an early and accurate diagnosis, what to expect during a memory loss workup in the clinic, whether you can trust a diagnosis that you receive from a medical provider. I'll also discuss reversible and alternative causes of cognitive impairment and memory loss. We'll talk about whether to see a primary care provider or whether a specialist is needed to make a diagnosis. And I also want to make sure by the time the presentation is over, everyone is clear about the difference between normal brain aging, mild cognitive impairment, and dementia. And then I'll conclude by giving you my top treatment recommendations and interventions. And lastly, discuss how family members and care partners can help. So let's start with why a diagnosis matters. How does it help? Unfortunately, in medicine, we don't have a very good track record when it comes to diagnosing dementia. In fact, we know that less than 50% of patients ever receive a formal diagnosis. So think of that, less than 50% of people with dementia are ever told what condition they have, get treatment or any kind of support. And so millions are left unaware, unprepared, and don't know what to expect. When we do make a diagnosis today of dementia, on average, we're telling people about their condition 2 to 7 years after symptoms began. And what that means is that the most common time that a diagnosis is rendered is during a crisis. For example, a hospitalization, the individual has fallen or had another medical issue that's brought them to the hospital, and people in the hospital are the first people to recognize and call out this person might be struggling with Alzheimer's disease or another dementia. Also, given years of experience working with families, oftentimes the diagnosis comes when the bottom has fallen out and family members and care partners are so exhausted, they're considering a placement, which, as you'll hear from me today, these are not the best times to be talking about a dementia diagnosis for the first time. So why is it that so many people never get a formal diagnosis, or when they do, the diagnosis happens so late in the stage of the disease? Well, there's a lot of contributing factors. For one thing, we're not used to talking about brain health. And when I say we, I mean we as patients and we as doctors and healthcare providers. And of course, you all know very well, there's a tremendous amount of fear and stigma about what a diagnosis means. And so even sharing concerns with the provider, saying, hey, I'm concerned that my memory is failing, is a very scary thing for many people to acknowledge. There's also ageism, and we're all susceptible to this. And the ageism that's pervasive in our society makes it very difficult for us to understand the difference between what normal brain aging looks like as we get older and how that differs from dementia. You've probably heard, and I hear all the time, you know, after all, what do you expect? She's 80 years old. And so we need to do a better job in the medical community educating providers about the difference and what to expect as people get older, what's normal and what isn't, and also help our communities and families understand the difference as well. Another challenge to diagnosis is that you, like me, probably are under the assumption that if there's something wrong, our healthcare providers are going to tell us about them. And that's just simply not the case. Again, many providers are susceptible to beliefs around ageism, may not feel comfortable with a workup or a diagnosis, and we'll talk a little bit more about that. But it's not always the case that our providers will call attention to an individual's memory loss. Importantly, the brain has historically also not been the focus of a routine exam. And so the brain is not on the list of so-called vital signs. We have vital signs which are checking a person's lungs, heart, to check vital organs of the body to make sure that we're functioning adequately. And somehow many, many millennia ago, we forgot to add the brain to that list. And so brain checkups are not standard procedure for most providers and most clinics. Of course, if you know anyone struggling with Alzheimer's disease or another dementia, you also know that many individuals who are in the throes of these conditions don't have full awareness of their symptoms. And of course, if you're not aware fully of what's happening, it's all the more difficult to acknowledge that in a setting of a clinic or with a healthcare provider. Doctors, nurses, social workers, we miss changes that happen in our patients very slowly over time due to our familiarity with the patient. And of course, you also know that most medical visits are very problem focused. You go to the doctor because of XYZ issue, and the 7 to 10 minutes that a primary care provider is able to spend with you is focused on the issue that you're coming to talk about. Time in the clinic is very limited. And of course, patients can also cover up deficits during short visits and by just chatting and answering questions. That the conversational back and forth in a 10-minute conversation is not a very good indicator as to whether someone is really struggling with memory loss or cognitive impairment. And lastly, I would just say that some providers, whether they're primary care providers or internists, may feel that they don't have the training or the tools or the comfort level to do a dementia workup or to talk about brain health or to make a diagnosis. So all of these things combined contribute to our poor track record. In primary care, when a provider feels that they don't have the tools or the comfort level to make a diagnosis, often what happens is something I call the eyeball method. So you come to see me in primary care, we have 7 to 10 minutes to discuss the problem you're coming for, and maybe you express or a spouse express concerns about memory loss. I don't have much time in 7 to 10 minutes, and so I will just sort of eyeball you and take a subjective impression of your presentation and use that as the primary basis to judge whether there's something of concern. And as you'll see in a few minutes, a clinician's subjective judgment without doing a formal workup is a very bad way of making a determination about dementia or not. So all of that is to say, patients, family members, the healthcare community, we all have our heads in the sand a little bit. Meanwhile, people are really struggling with a lack of information and lack of help. So quickly, I want to talk with you a little bit about why should you pursue a diagnosis? Is that even important? Why does it matter if a person has Alzheimer's disease or vascular dementia or frontotemporal dementia? Aren't they all sort of the same and lead to the same place? Of course, as I'm reviewing these rationales, a person only needs one reason, And so whatever reason resonates the most with you is enough to justify pursuing a diagnosis. The first one is that a diagnosis that's specific and timely can improve a person's quality of life. For one thing, a decision can be made as to whether medication or non-medication strategies and treatments might be of benefit. And I can't tell you in my 25 years of practice how relieved patients and family members are once they have tangible information and some guidance about, again, medication and non-medication strategies that can help. I think the other problem in medicine is that we've been very paternalistic in our history. That is, the doctor may be aware of a concern, but in the past has decided when and if to tell patients about their diagnosis. Patients and families historically have not had easy access to their medical records. And all of that has been changing very slowly toward person-centered care under the belief that it's important to give people information, a diagnosis, a treatment plan, and then ultimately it's up to each person to decide whether they want to follow the recommendations or move forward with the treatments. I would also mention that information, a diagnosis, increases the support for family and friends because they know what to expect and how to help. Secondly, we know from research that a specific and timely dementia diagnosis translates into, on average, people being able to stay at home for longer periods of time. No matter who you are, where you live, your cultural background, chances are that one of your priorities around getting older is staying at home as long as possible. Most of us share that value. And knowing what to expect and what to do, how to help, connecting with community resources and supports as soon as possible translates into more independence and a longer ability to stay at home. Third, improving health and longevity. Having dementia, Alzheimer's disease, or a related condition has great implications for how other diseases and diagnoses are managed. For example, diabetes. People with dementia who do not have very well-controlled blood sugars, we know that those two things don't mix well together. Poorly controlled blood sugars hasten or can speed up the memory, cognitive, and functional declines that people experience, increasing their risk for needing more support, hospitalization, and placement. So if we know about a dementia diagnosis, we're better equipped to be able to manage all those other health conditions that can intertwine and play a big part. Number 4, it's possible during the dementia workup to find reversible causes of memory loss. And I'll talk more specifically about what the workup entails in a few moments. But it's not uncommon that people present in the clinic with things that we can do something about. That might be vitamin deficiencies, again, blood sugar issues, significant depression, conditions that can mimic the symptoms of dementia. Number 5, knowing what to expect and how to treat. So different forms of dementia have distinct, varied, different symptoms. The rate of progression or the course of the disease can be vastly different. And sometimes the treatments are also very different. So for example, in the context of Lewy body dementia, we know that those individuals, in addition to confusion, memory loss, cognitive symptoms, also can have tremors, imbalance, and are at a very high risk of falling. If you know the difference between Alzheimer's disease and Lewy body dementia, you can help the family prepare in advance for those known symptoms that will appear at some point to protect the individual, make sure that they're safe, they're not having falls, head injuries that land them into the hospital or a nursing home. And it's also important for medication treatment. For example, someone with Lewy body dementia should not be given certain types of medications to treat hallucinations because that can increase the risk of death. And so there's all kinds of reasons why knowing what type of dementia a person has is extremely important. And lastly, I would just say a specific and timely diagnosis, we know that helps to keep people out of the hospital or reduce the number of hospitalizations. And again, you don't want to receive this information during a crisis when the individual is wandering, they're having car accidents, falls, and head injuries. This reminds me of the philosophical thought experiment regarding, if a tree falls in the forest, but no one is around to hear it, did it actually make a sound? Well, of course it did. And when it comes to a dementia diagnosis, if you don't seek or obtain a diagnosis, does it mean that the condition disappears, isn't relevant, doesn't dramatically impact the individual and the entire family? No, of course not. And so having a diagnosis is power. It's more information and gives you more opportunity to take steps and be proactive. So with the rationale explained, I want to talk more specifically about how these dementia conditions are actually diagnosed in the clinic. So what can you expect when you see the doctor? What does a gold standard workup look like? First, because many of us are concerned about finances and specifically unexpected medical bills, I just want to point out that the standard dementia workup is something that is covered by Medicaid and Medicare and the vast majority of insurance companies, whether you complete that workup in primary care or with a specialist such as a neurologist, a psychiatrist, or a geriatrician. So in the vast majority of cases, this is a covered medical process. So how is it in clinic that doctors or healthcare professionals diagnose dementia? Well, the core or the standard workup includes a medical history, a physical exam, something called a neurological exam, and lab tests. And then in some cases, there are optional diagnostic tests that can also be performed, including a brain scan, mental status exam, which is memory and cognitive testing, and a functional assessment. What's important to know, and I'm going to go into more detail as to what each of these components look like, it's important to know that no single test can diagnose dementia. We need all of the core pieces of a standard workup in order to make that diagnosis appropriately. So what's a history and physical? Well, this is the most standard part of seeing your healthcare provider. A history is simply a conversation. Your primary care provider wants to know about relevant medical conditions that might be going on that could be causing memory loss, confusion. Confirm your medication use. Sometimes there are medications that have cognitive side effects. We want to know when your symptoms of memory loss or confusion began. And are they the same more or less every day? Do they fluctuate? Is there anything that triggers these symptoms to occur? Have they remained stable over time? Do you think they improve at times? Are they getting worse? And have these cognitive problems or memory changes had any impact in the person's everyday function? And I'll explain a little bit more in a second what I mean by that. Your provider will also ask you about mood. So have you been feeling a lot of anxiety, stress, depression? Or how much alcohol are you drinking? So all of these questions are geared to help us better understand and rule out other potential causes aside from dementia that could be contributing to the cognitive problems. And a physical is just a routine physical exam, just checking, again, your pulse, your blood pressure, your respiration, all of those routine parts of the body. Another essential component of a memory loss workup is a neurological exam. Now, I want to point out and make it clear, because this is one of the knowledge questions, that all primary care providers are taught how to do a neurological exam. So obviously, neurologists do a neurological exam as well and are specialists, but primary care providers can also do these exams. So what do they look like? Well, a neurological exam is testing different parts of the body to give us clues and hints about how the central nervous system or the brain and spinal cord are functioning. So in a neuro exam, the provider is looking at your posture, looking at your gait, your balance, and your coordination. They may test your muscle strength by asking you to make a fist around or hold on to their hand or grip their hand or finger. We'll test your reflexes by the usual hammer on the knee or elbows or other parts of the body. Sometimes we test sensations, so that could involve smell, your sense of touch or hearing. And then usually a neuro exam also includes looking at the eye movements and visual fields. So again, all of this is very straightforward, and primary care is capable of doing a basic neurological exam. Cognitive screening. This is another core part of every standard dementia workup. And without it, we are not getting full, complete, or necessarily accurate information about how the person is doing. I mentioned before that most primary care providers only have 7 to 10 minutes in the clinic, and so often base their judgments about a person's memory just on conversation. Well, we've all been talking since we were 2 years old, so that's a very overlearned, ingrained skill that remains intact until the very end of most dementia conditions. And so it's not a sensitive way of determining whether a change has occurred in the brain. What is needed is something objective, tools that can help us tell the difference between whether someone's memory loss is a normal part of aging or abnormal. So cognitive screening measures are short tools. Typically they take 1 to 10 minutes, and it's asking the person different types of memory questions and basically trying to do some mental gymnastics with them. These tasks typically yield a total score, and then that total score is used to determine, is the person functioning normally or not. I just want to show you how important the use of these objective screening tools are. So this is one of many studies from a number of years ago by Sue Borson. And this shows the difference, the detection difference between using one of these tools, in this case called the mini-cog, versus a medical provider's eyeball subjective opinion as to whether the person has memory loss or is impaired. So along the bottom left to right in these columns, the first column is mild cognitive impairment. The next column is individuals with mild dementia, then moderate dementia, and severe dementia. The green bars are how accurate the mini-cog is in detecting abnormal cognitive impairment. The yellow bars show how accurate the medical provider is without doing screening and just using that eyeball approach. These little asterisks show you that the difference between this screening tool and the medical provider's subjective opinion are statistically significant. And what you can see is that in almost every case, these cognitive screening tools far and away are much more accurate than an individual's subjective opinion. And this is true even for a specialist who doesn't use cognitive screening tools. The only exception is when people enter into the final stages or the most severe stages of dementia, when you don't need to do cognitive screening because it's very apparent and obvious to everyone that the person has dementia and is very impaired. But prior to that stage, you can see there's no question these tools make a huge difference. Laboratory tests, blood work, are also part of a core standard dementia workup. So what are we doing here? Well, as it stands today, there is no blood test that can be used to detect Alzheimer's disease or other dementias. But I want to tell you that we are very close to such a test. My prediction is that within the next 5 years, there will be a blood test that is commercially and clinically available. in healthcare settings that will do just that, that will help us as a first round biomarker, tell us if someone has Alzheimer's disease. But for now, this blood work is really about ruling out other things that could cause memory loss or cognitive impairment. So we're looking at the number of white and red blood cells in your bloodstream, looking for signs of a possible infection or inflammation. Glucose is also commonly measured. Again, low blood sugar can have a huge impact on the brain's functioning and memory. TSH, or thyroid stimulating hormone, is an indication as to how well the thyroid is pumping out the appropriate stuff. And if this lab is abnormal, people can also have cognitive changes. But thyroid, low thyroids, high thyroids, that's something that we can treat. Vitamins and nutrients, vitamin B12 and D are other things that are often tested for to make sure a person isn't low. So laboratory studies, blood work, very standard part of the workup. Now, I also want to mention that there are optional diagnostic tools that are also used at times when people go to the clinic. So these are not needed in every case, but I want to explain a little bit more about why they might be needed and when. So the first thing is a brain scan. Does everyone who goes for a dementia workup need a brain scan? No. Oftentimes a neurological exam that we reviewed earlier is enough to give us an indication as to how the brain and spinal cord might be working. If someone has had a brain scan already within the last 2 years, we typically say that they don't need to have another one. And the purpose of these brain scans is really to rule out other causes, non-dementia related issues that could be contributing to memory loss. So for example, has someone had a stroke that they are not aware of? Do they have cerebral vascular disease? That's related to wear and tear of the small blood vessels in the brain, which if you have enough of this wear and tear, you can have memory and cognitive symptoms. Is there a brain tumor or something called normal pressure hydrocephalus? We all have these fluid-filled cavities in the brain, that's normal, but in normal pressure hydrocephalus, the amount of fluid is in excess. There's too much in these ventricles. The ventricles become too large and they start pushing and crowding brain tissue, which then can lead to cognitive problems. So the purpose of a brain scan is really to rule out these other issues. It's actually very rare with a traditional CT or MRI to, quote, see dementia. And that's because it's not typical to really visualize structural changes in the brain until much later in the course of the disease. That's not always true, but it's true in a lot of cases. It's possible, for example, to have a diagnosis of Alzheimer's disease and to have an essentially normal brain scan. So the determination as to whether a person needs a brain scan or not is determined on a case-by-case basis. You may have also heard about neuropsychological testing. This is really detailed measurement of all of the different thinking skills. And that includes focus, concentration, person's ability to multitask, their memory, their comprehension and language, their processing speed, which is how fast they're able to think and make sense of information, spatial skills, their problem solving and judgment, mood and behavior. And so a neuropsychologist over the course of a few hours takes detailed measurements. And at the end of that exam, it gives us basically a numeric mapping of how these different networks in the brain are working. A neuropsychological exam can yield 50 to 100 or more data points. And then what we look for in that data is a fingerprint, a signature that can tell us, this is normal aging, this is Alzheimer's disease, this is the effect of medication or some other cause. So in some cases, neuropsychological testing can be very useful. This data, as I was just mentioning, helps us to tell the difference between dementia, normal aging, or memory complaints. We can also identify and distinguish pre-existing cognitive problems. For example, maybe someone has a learning disability or dyslexia, We're able to determine and see that in the data and talk about how that might affect the person in older age. We can tell the difference between Alzheimer's disease and mental health related cognitive impairment, or the impact of medications or current or past alcohol or drug abuse. Individuals with chronic pain can also have cognitive problems. People with significant insomnia, obstructive sleep apnea, and of course, complex medical conditions. And another benefit of this testing is that we can better hone in on the specific or precise dementia condition. Is it Alzheimer's disease? Is it vascular dementia? Some combination or something else. Lastly, regarding neuropsych testing, I would just say that we can also use this information to make a lot of specific recommendations. So, a younger person who's maybe early on in the course of a dementing condition, can they still work? Or do they need disability benefits? Can the individual remain at home independently? Or do they need some types of support or placement? What about their ability to drive or cook safely? Do they have the capacity to manage finances or make healthcare decisions? What type of rehabilitation techniques might be beneficial? Are there mental health interventions that could improve their well-being? Are there medical needs, for example, a sleep study? Or what types of education and support can we offer very specifically based on the data for patients and families? So another optional part of the dementia workup, not always used, but determined by the provider based on the individual circumstances, something called a functional assessment. So whereas a neuropsych assessment is evaluating brain function and cognitive abilities, this functional assessment by occupational therapy is looking at the person's real world abilities to complete everyday tasks. For example, in the lower right-hand corner, you can see this woman filling up a pill box. And so an occupational therapist might give the person in writing some instructions, some pill bottles, and see if they're able to follow the instructions and keep track of the medications. On the left part of the slide here, you can see so-called instrumental activities of daily living, or IADLs, which are things like preparing meals, shopping, housekeeping, using the telephone. And on the right, more basic activities of daily living, or ADLs, things like bathing, hygiene, dressing, eating, and using the toilet. So all of these things can be evaluated during an occupational therapy functional assessment. I also just wanted to mention, in case you're curious about the horizon, what's new in terms of diagnostic tools in the clinic. These are not things that are used routinely in clinical practice today, but will be used more and more in the future. And really, this comes down to biomarkers. Biomarkers are biological evidence of a disease condition. And I already mentioned blood testing. That's the holy grail. That's the easiest, simplest, and most cost-effective way of the future in determining who has Alzheimer's disease or another condition. And again, I think we are very close to making that a reality. There's also something called PET scans, which are used a lot in research. Those measure the metabolism or the energy that different parts of the brain are expending, and that pattern can help us understand what type of dementia an individual has. In research, we also have scans that can detect the brain pathology associated with Alzheimer's, called amyloid or tau. And then that cerebral spinal fluid I mentioned earlier in the brain is also in the spinal cord. And so we can do something called a spinal tap, which is inserting a needle into the spinal column, extracting a small amount of cerebral spinal fluid, and then analyzing that for these abnormal pathologies, amyloid and tau, which can give us very good information about whether someone meets criteria biologically for Alzheimer's disease or not. So again, none of these are used today, but more and more will be used in the future. So given what I've said about all of these different components of a dementia workup, how much can we trust a diagnosis? So What does the literature say about diagnostic accuracy? Well, there are some conditions under which diagnostic accuracy can actually be quite high. And to summarize, accuracy increases when people are older, over the age of 65. And that's because the older you get, the more likely certain of these dementia conditions become. Diagnostic accuracy is high when a patient completes the standard workup. And so not getting a workup or only getting a partial workup because the individual refuses or is not inclined to proceed lowers the accuracy that we have. And then diagnosis is also more accurate when someone presents with more common symptoms as opposed to more rare or unusual symptoms. For example, diagnosis accuracy is higher when the first symptom that they have is not trouble recognizing faces or obsession with certain types of food, for example, those that are soft or sugary, or a loss of social skills or significant language deficits. If a person experiences any one of those or a number of those symptoms as the first symptom or an early symptom, that would be atypical for Alzheimer's disease, for example, and really means that the individual should probably see a specialist to refine the diagnosis. So our diagnostic accuracy is much more variable when people are younger than the age of 65, when again the patient refuses the exam or parts of the exam, or when the individual has atypical presentations or a very complex medical history and they only see a primary care provider. But for the vast majority of individuals, our ability to accurately diagnose Alzheimer's disease and other dementias is very good. I want to say a little bit more about reversible and alternative causes of dementia. It's not always Alzheimer's disease. I mentioned earlier, vitamin, nutritional, and hormonal deficiencies are one bucket or category that can lead to cognitive impairment. That means undiagnosed thyroid conditions, hormonal disorders, endocrine problems, frequent low blood sugar, also called hypoglycemia, very low B12, drug interactions and medications with cognitive side effects. For example, it's very common for me in clinic when we start a dementia workup to hear that a person is having some sleep difficulties, as a lot of older people do, that they're taking Benadryl over the counter to help with sleep. Well, Benadryl has certain properties that actually deplete the brain of a certain chemical that is needed to form memory. And so that's an example of a so-called bad brain medication. And we would want to try to take that away, offer a substitute that's safer for the brain, and see how the person does. So there are many drugs and things over the counter that can lead to cognitive side effects. Problems with other organs. So one example is non-alcohol related liver cirrhosis or failure. People can have this condition and not be aware of it and experience memory difficulties. We talked about normal pressure hydrocephalus. There's a good portion of patients who I see who report, or their spouse reports, that they snore and they've never had a sleep study. And we send them to have a sleep study. And lo and behold, they have an undiagnosed obstructive sleep apnea condition. Now, sleep apnea is one example of a condition that over time, very slowly, can lead to cognitive problems. If you have sleep apnea and it's not treated, your brain is not getting a sufficient flow of oxygen every night. And if you accumulate the damage that's caused by that over days, weeks, months, and years, it adds up to irreversible damage in the brain. Again, that leads to cognitive problems. And so that's one example of something that we can do something about. We can treat the condition and hopefully stabilize the cognitive losses as that individual ages so that they don't worsen. So there's lots of things that we're looking for lots of ways that we can help people's brain health improve. And the last one I'll mention here is severe depression. When depression or other psychiatric conditions, mood disorders, are severe enough, people can also have confusion and memory loss that mimics dementia. But of course, depression is usually something that we can treat very well. Now, I think most of you appreciate the fact that neurodegenerative conditions like Alzheimer's disease are not something that appear suddenly overnight. Most of these dementing conditions are very, very slow to evolve. The exception being, for example, if someone had a massive stroke, that is a sudden onset, potentially cognitive impairing condition, or someone had a head injury with bleeding in the brain. But barring things like that, if someone presents with what we call rapid onset confusion, it's likely that there are other things to blame or that are contributing to that rapid fall. Often that has to do with medication side effects or an infection. And usually that's related to a urinary tract infection or UTI. Dehydration, we talked about uncontrolled blood sugars, other psychiatric conditions, and even significant and chronic sleep deprivation. Now, Alzheimer's disease is just one type of many forms of dementia. And so I'm just highlighting on this slide the four most common types of neurodegenerative dementia. If you took 100 people with dementia and didn't do a workup, and you guessed all of them had Alzheimer's disease, you would be right in 75% of cases. So 3/4 roughly of all cases of dementia are caused by Alzheimer's disease. Lewy body dementia, though, is next in line, 10 to 25%, and that's on the Parkinson's disease spectrum. It involves cognitive problems, memory loss, but also imbalance, frequent falls, and a lot of visual hallucinations. Vascular dementia, 6 to 10%, of course, that's caused by stroke or vascular breakdowns in the brain. And lastly, frontotemporal dementia, which, as the name implies, affects the frontmost part of the brain and can lead to a lot of difficulties or changes in personality or a person's speech. So I also want to address whether a person should seek a diagnosis from primary care or a specialist. Which is best? Well, my usual recommendation is that people first try to start with their primary care provider. It's a good place to start in most cases. Usually that person knows the patient fairly well and has a lot of background about them. Primary care is also a good place to start if someone has memory or cognitive problems and they're over the age of 65. Of course, it's only doable if the provider agrees to do a workup. And remember that a standard workup includes the history and physical, the blood work, and must include, in most cases, these objective memory screening tools. It's also important that the person or that you, your family, get a diagnosis that's more specific than just memory loss or dementia. Again, dementia is caused by many different diseases. And so the person you're seeing should be able to tell you what they have, what their hunch is concerning the most likely cause. Now, again, I'm going to talk about this a little bit later toward the end of the presentation, but I do want to acknowledge that many families and patients are frustrated with the fact that they have brought up concerns about memory changes and their primary care provider may be dismissive, again, may not be willing to do a workup, may not have the interest in that or the time or the tools. And we'll talk about a little bit later some ways of working in that situation if you've experienced that or do experience that in the future. When should you see a specialist? And most commonly, the specialist for a dementia workup is a neurologist. Well, If you're younger than 65 and you have memory or cognitive problems, a specialist is really best. And that's because there's just so many different things at that age that can contribute, and making a dementia diagnosis is a little bit trickier. If you have unusual symptoms like, and these are just a few examples, muscle jerking, tremors, frequent falls, a lot of visual hallucinations very early in the course of the disease, those unusual symptoms or complicating symptoms beyond just standard memory loss mean a specialist is probably best. And of course, a specialist is who you're going to go to if a primary care provider is not willing to investigate the issue. Even if you see a specialist, there's different ways of managing a person's dementia over time. And I've broken this out into two large categories. On the left, you see diagnosis only. You can go to a specialist just for the purposes of doing a dementia loss workup, getting a diagnosis, and getting a treatment plan, and then going back to your primary care provider. And this approach is really best if your primary care provider is comfortable prescribing, refilling, and following the treatment recommendations of the specialist or the neurologist. On the other hand, there are some conditions where following with a specialist for dementia throughout the course of the disease may be better. And that's when your primary care provider is uncomfortable or not inclined to treat you, or you have more confidence in the specialist, or your diagnosis is something other than Alzheimer's disease. A specialist is really best for non-Alzheimer's related dementias. Again, I'm going to come back to some of the challenges in seeing a specialist versus primary care at the end of the talk. I mentioned that I also didn't want to leave you without clarity regarding the cognitive continuum, normal aging, mild cognitive impairment, and dementia. What's the difference between these things? In normal, healthy aging, we have cognitive loss that happens to all of us. And so there's a very characteristic pattern. First, we all know we have sensory and motor declines. Our hearing, our vision, and our balance deteriorates to a mild extent. We also, you may not know, have a general slowing of our processing speed. So this means that we have a lot of information in our heads as we age, but it just takes a little bit longer to find the information because of the sheer volume of memory and facts that we've accumulated over 60, 70, or 80 years. So our thinking slows down a little bit. Our wisdom or our intelligence remains stable in normal aging. But we also have a mild decrease in our ability to recall the names of people, places, or objects. I call this the whatchamacallit syndrome. I'm already starting to have this. Just the other night, my wife was making dinner and I wanted her to hand me the spatula. I had trouble coming up with that word. So we laughed about that. But that kind of word finding problem is a normal part of getting older. Also, there's a decline in mental flexibility. So for example, being able to do math problems quickly in your head is not as easy. And there is a certain degree of memory change that happens with normal aging. You know, we've probably most of us have had senior moments or golden moments. For example, getting up from the living room, going into the kitchen and thinking now, dang, why on earth did I come in here? And then you go back to the living room, sit down, and then it occurs to you, oh, that's right, I was going to get something to drink. So all of that is normal aging. The difference, though, is that despite these mild changes in our thinking, we're still fully independent in all of these daily activities. So we can still operate appliances, the microwave, the coffee maker, a toaster. We can pay our bills and we're aware of our financial status. We can manage medications correctly and drive safely and shop and prepare meals and so on. Our memory is also intact for recent events. So in normal aging, if you ask someone what they did this morning, they should be able to tell you that. And most importantly, the difference between normal aging and abnormal aging often comes down to a person's performance on these objective cognitive screening tests. These tests, as I mentioned before, have been well researched and are doing an excellent job of distinguishing normal from abnormal. So what is mild cognitive impairment? Mild cognitive impairment, as the name implies, is mild but measurable changes in thinking ability. In mild cognitive impairment, the individual performs abnormally when we give them a memory screen or when we perform neuropsychological testing. And unlike dementia, their functional abilities at home is still, they're still more relatively preserved. So the individual, for example, may need more prompting or reminders to take their medications or pay bills. But in mild cognitive impairment, they are, at the end of the day, able to complete those tasks. What is dementia? Dementia is a brain condition that causes a decline in memory and intellectual functioning from some previously higher level that's severe enough to interfere with everyday life. And of course, dementia is not normal aging. Senility and dementia is never normal, no matter how old a person becomes. A common question is, what's the difference between dementia and Alzheimer's disease? Isn't dementia the word we use to describe mild or moderate symptoms, and Alzheimer's disease is what we use to describe more severe symptoms? That's not true. Alzheimer's disease can be mild stage, moderate stage, late stage. The difference between dementia and Alzheimer's disease has nothing to do with severity of memory loss. So if I say the word flowers, we all have pictures of different types of flowers that come into mind: tulips, roses, mums. And the same is true if we use the word dementia. Dementia is just a broad umbrella category, a generic word, under which there are many specific diseases that cause dementia. We already talked about Alzheimer's disease being the most prominent cause in 75% of cases, but that there are these other specific contributors as well. And on this slide, I'm just showing you there are many, many, many things that can cause dementia, not just Alzheimer's. So you can have dementia from HIV/AIDS or multiple sclerosis, or mad cow disease, also called Creutzfeldt-Jakob disease, Wernicke-Korsakoff's, which is alcohol abuse related dementia. So many, many specific types of dementia. Alzheimer's disease is something we talk about the most because it's the most common. And Alzheimer's disease, as you know, is a slowly progressive degenerative condition in the brain. It leads to memory and other thinking skills that decline over time, severely enough to really impact a person's ability to live independently. And Alzheimer's disease is related to very specific types of pathology in the brain, and unfortunately, today is not reversible. Something that may surprise you is that we know now that the brain changes or the brain pathology related to Alzheimer's disease begin 1 to 2 decades before a person actually shows any signs or symptoms of the condition. So that shows you just how slowly progressive and how resistant actually our brains are at compensating and dealing with this accumulating pathology, that it would take so many years for symptoms to actually appear. How common is Alzheimer's disease? Well, if you're over the age of 65, it's about 11% or 1 in 9 people. If you're lucky enough to live into your mid-80s, the chances of having Alzheimer's disease just based on age alone is about 1 in 3 people. And at the bottom here, you can see that the vast majority of people with Alzheimer's disease are over the age of 75. Unfortunately, certain populations are at a higher risk of Alzheimer's disease. Women are much more likely to have Alzheimer's disease. It's thought because of a longer life expectancy. Non-white populations, unfortunately, are also at a higher risk. So for example, older African Americans are at twice the risk as Caucasians. Older Hispanics at 1.5 times the risk as their white counterparts. Scientists don't yet have all the information here, but they suspect that this disparity has a lot to do with health inequities, differences in socioeconomic status, and knowledge about medicine, trust in doctors, and lifestyle factors. Alzheimer's disease is the 6th leading cause of death. And if we could detect it earlier, that is when those brain changes were first starting, of course, the prevalence would be much, much higher than it is today. So I just have a couple more sections and then we're going to open it up for questions, but I wanted to give you some information about top treatments and recommendations from a memory loss specialist. Based on research and conversations with families who have dealt with Alzheimer's disease or other forms of dementia, that research shows that there's really 8 things that families want, need, and deserve when they're experiencing somebody in the family with memory loss. And that is timely detection, a clear diagnosis, proactive care on the part of the medical community, referral to education and support services, really a team approach to their medical care that involves and listens to care partners and family members, the opportunity to participate in planning and decision-making, access to medical care coordination, some assistance with making sense of where to go and coverage for different treatments and interventions. And then lastly, communities that understand dementia and are supportive. And there are many initiatives around the country to try to improve on these different things. Medication is not the primary reason to seek a dementia diagnosis. In fact, when a dementia diagnosis is made, often it's about reducing medication. So this is one of my favorite cartoons, one woman coming in to see her provider. I feel a whole lot better since I ran out of those pills you gave me. So we try to emphasize reduction of medication and simplification. Just quickly, you all know that there are some medications that are FDA approved to treat Alzheimer's disease and other dementias. Those are listed on the slide here. These medications do nothing about the brain pathology. The brain pathology continues to accumulate, worsening the patient's memory loss and functional abilities. The medications, though, can slow the progression of symptoms for some patients. Often the effect of these drugs is about 12 to 18 months on average. But again, they do not slow or alter the brain pathology. You may have heard earlier this summer that there's a new drug that was just recently FDA approved for the treatment of Alzheimer's disease called aducanumab. And this was a very controversial decision by the FDA. Basically, this is not an oral medication. It is an infusion drug. That means that it's delivered via IV. And basically, it's an antibody treatment. So it goes into the bloodstream, into the brain, attaches to this abnormal pathology amyloid, and then takes amyloid out of the brain, thereby reducing the amount of pathology in the brain that the person is experiencing. However, in addition to questions about whether it is effective in really helping people's memory and thinking abilities, the cost is estimated at almost $60,000 a year. And the Institute for Clinical and Economic Review, which reviews how much bang for the buck people receive with medications, estimates the actual benefit of the drug is much, much lower. There are a lot of questions concerning this medication, and basically Medicare and Medicaid have not said whether they will cover the drug. And of course, if it's not covered, only the rich will have access. So we're excited about this new drug, but more research is needed. And there's plenty of experts saying that they're supportive of the FDA approval and many others saying they're critical. Basically, more research is needed to determine outcomes. In terms of non-drug interventions, I want to talk about brain wellness. This is a guide called Living Well that's free and available online at this website. It's a little bit long, but this will get you to the PDF online. This is a guide that my wife and I wrote with a neurologist using all of the research on brain health, how to lower a person's risk of getting dementia, and some tips and tricks to improve quality of life and focus on wellness. So check out the guide if you have interest in non-drug interventions. Addressing behavioral challenges, again, you will get access to the slides, so I won't spend too much time here, but if you're working with someone who has behavior challenges, all of these books and resources are extremely helpful. In terms of getting support as a caregiver, well, the Aloha chapter of the Alzheimer's Association, you can see the phone number on the website here, just an excellent resource. The services are statewide and they have access services in every county, information, referrals, all kinds of support, and a 24-hour helpline. So a good resource if you have questions. I always recommend patients who are diagnosed with dementia that they see a pharmacist. This is a covered benefit by Medicare. A pharmacist can help to review medications, get people off bad brain drugs, simplify their medication strategy, make it easier to use, and improve the likelihood that someone is actually going to take the medication as prescribed. So you can ask your doctor about a PharmD consult. Driving, we could do a whole talk on driving, but I just wanted to point out that the Alzheimer's Association has a portal on their site that has short videos showing how, as a family member, to talk with your loved one about concerns regarding driving, and a lot of other really, really good resources. And then on the right, the At the Crossroads is a free resource from the Hartford, which also provides just a lot of really helpful information about this issue concerning driving. As we wrap up here, I want to review the knowledge questions. First one, only about 80% of individuals with dementia ever receive a formal diagnosis. That's false. Less than half, less than 50% of people ever receive a formal diagnosis. A brain scan, MRI, or CT is a necessary component of the standard dementia workup. That's also false. We talked about how that's determined on a case-by-case basis. Number 3, only a neurologist can perform a neurological exam. Also false. Primary care providers are trained on how to perform a neuro exam as well. Number 4, mild to moderate memory impairment is referred to as dementia, whereas severe memory loss is called Alzheimer's. That's also false. Again, these words have nothing to do, Alzheimer's has nothing to do with what stage. You can have mild Alzheimer's disease, moderate or severe Alzheimer's. Number 5, the primary reason to get a diagnosis is to start medication treatment as soon as possible. False. Again, we've talked about how the drugs offer some benefit for some people, but don't modify the disease or change its course. But there are many, many, many other reasons, many interventions, supports, resources that can be brought in to improve quality of life, keep people at home and out of the hospital. So in the last few minutes, how can you help? So your loved one or a friend is reluctant to see the doctor about memory. This is a common issue. You can focus on the positive, statements like, I love you and I want us to stay healthy together. Will you do this for me? You can tell them that you attended a talk and heard that there's an opportunity to find reversible causes and to treat those causes and stabilize or improve people's memory or cognitive status. Or you can send the medical provider a message with your concerns in an email or a phone call before your loved one's annual exam or next appointment. When you do that though, keep your list of concerns concise, to the point. Tell the doctor or healthcare provider about the symptoms, what you're concerned about, when they started, and if they're getting worse or not. Ask for what you want. Tell them you want a standard dementia workup to occur. And you can also make an appointment for your loved one, but don't necessarily need to tell them that it's for memory loss. Just tell them that it's a routine visit to help them get to the clinic, and then let the provider navigate that conversation about memory loss from there. Our provider won't do an evaluation or hasn't told us much. Well, again, you can send a provider a message with your concerns. This technique is vastly underutilized by people. Sending emails or phone calls and talking to the nurse gets these messages in the chart. So again, ask for what you want. You want a standard dementia workup. You're struggling. You need help. Please help us and do the workup. Or you can ask for a referral if your primary care provider is unwilling to do a workup. Ask them for a referral. Maybe there's another healthcare provider in the same clinic or in the same practice that can do this for you. Or you can ask them for a referral to see a specialist. But remember, you can self-refer and still have it covered by Medicare and other insurance types. I also just want to acknowledge that I know that there is a gross shortage of specialists around the country, and particularly in Hawaii, depending on what island you live on. So that's not lost on me. This is true for, again, many, many states around the country, and is a very difficult situation. So understand that you're not always going to be able to have access to specialists, and it's all the more important then to try to see someone else. Another strategy is to contact Catholic Charities, the Alzheimer's Association, or these other resources, and explain the problem, because it's likely by word of mouth, those organizations likely are aware of other clinics, systems, providers who are more willing and capable and confident at doing these workups, and they can guide you in the right direction. It's also okay to seek a second opinion on your own, so don't be afraid to do that. Lastly, I'm afraid to say anything. Well, again, send the provider a message with your concerns. Ask them to bring it up during the patient's visit, and make it clear that during the visit, you're not going to be able to say much about your spouse's or family member's memory loss because it's too upsetting. Go with the patient to their appointment, and you can pass the nurse a note when they enter or leave the room, indicating your concerns and asking for a workup. Again, just some strategies that people have told us have been helpful in trying to facilitate information. So I've gone a little bit over time, but I do have time for questions. So I'm going to stop there, and again, just thank the sponsors for having me.
Thank you so much, Dr. Barclay. That was amazing. You can stop sharing the slides. We have the poll up again, the same questions. We're hoping that you can all answer the poll and had plenty of time to understand the questions. We'll move to Q&A now, and I'll give you the questions. Dr. Barclay, you really demystify this whole thing, and it's very evident why you are in great demand nationally and even around the world. As a dementia expert, you're so clear about all of this. Thank you so much. I'm going to go off camera and start giving you the questions. All right. First one is, what age would you recommend to ask for or request for a brain checkup?
That's a great question. You know what? You're never too young to talk about brain health, especially given the frequency of these dementias as we get older. And so no matter what age you are, asking your doctor about memory loss, establishing a conversation, talking about brain health, what things can you do now to lower your risk, are all really good conversations to normalize that kind of dialogue. But the recommendation for healthcare systems is that they start to objectively test for brain health at the age of 65. And that's because it's at 65 and older when the rates of these dementia conditions start to become more and more prevalent. And that increased prevalence justifies the extra time it takes to do some of these objective measures for a couple of minutes. So in the future, this will be a routine part of your annual exam. In addition to vital signs, your healthcare provider will do the mini-cog or another cognitive screening instrument with you as routine, which will then help to facilitate a conversation about brain health and memory challenges and lead to more workups. But you're never too young to ask about brain health.
Thank you. My 97-year-old father's PCP said that he tried to give my father a cognitive test, but because his hearing loss is so great, it was difficult. Dad can read questions, etc. What do you recommend?
That's a really great question, because of course, Vision loss and hearing loss are very common as people get older, particularly in the 90s. As a neuropsychologist or a specialist, when people come to me with that problem, I use a very simple hearing amplification device that I purchased at Radio Shack that basically just involves putting a headset on the patient and speaking into a microphone. And that has done wonders because I can ask my questions, I can do any screening instrument that I want and get around that memory issue. But you could also tell your provider that there are low vision and hearing loss versions of many cognitive screening instruments. For example, the MoCA, that's called the Montreal Cognitive Assessment Test, MoCA, the MoCA. The MoCA is translated also into many, many different languages. So can be used in combination with an interpreter and can also be used in low vision and low hearing scenarios. So this is a challenge, but hearing amplification devices, very inexpensive and great to use in that context. And then also helping the provider know that there are tools that can be used that are specially designed for these types of things.
Thank you. Wouldn't a brain scan be productive in determining the type of dementia, i.e. Lewy body versus Alzheimer's?
You would think so, but in most cases, no. The different forms of dementia do cause atrophy or shrinkage of specific parts of the brain. But as I mentioned, it's not easy to visualize that on these brain scans until, pretty far into the disease. I don't know if people have seen many brain scans, but, they're kind of akin to ultrasounds that pregnant women have. And you see those very fuzzy pictures and, half the time, since I'm not a pediatrician, don't deliver babies, can't make sense of those images. Brain scans, it sounds very fancy, but at the end of the day, those images are also a little bit grainy. And historically, providers have used an eyeball method to look at those scans and determine if there's anything wrong. More recently, and as a specialist, I have this available in my clinic, there is a technique that can be used in a brain MRI that actually measures the volumes of the memory center and different parts of the brain. And then we compare that volume in our patient to what's normal for someone of their age. And so if you have that type of software like a specialist would, you can use a brain scan to see, aha, there's too much shrinkage in the memory center of the brain. That's a characteristic hallmark feature of Alzheimer's disease. That increases our confidence in that diagnosis. But in most settings in primary care, no, a brain scan is not going to help to determine the differences between different types of dementia, with the main exception being vascular dementia, where you might pick up on some strokes.
Thank you. Is it possible to stop the progression of Alzheimer's disease when diagnosed early?
No, it's not possible to stop the progression today. So getting a diagnosis, I wish we had some kind of magic bullet, and the new medication that I mentioned that was just FDA approved this summer offers some hope that eventually we will be able to stop the brain pathology and arrest the disease and either stabilize people from getting worse or help them to improve. But today there's no medication treatment that can do that. So getting a diagnosis is not about stopping the disease. It's about information being power, being able to be proactive, plan ahead, and access resources and supports. And again, the research on this is exquisitely clear. People who get a clear diagnosis in a timely fashion are more prepared. Family members feel more comfortable and confident. People can stay at home longer, avoid hospitalizations. So those reasons alone, I think, are enough to prompt us to seek more information in a specific diagnosis.
Can you have both frontotemporal dementia and Lewy body dementia?
You could, but it would be exquisitely rare. So most people with frontotemporal dementia have a very specific type of brain pathology and accumulation of something called TDP43. which is completely different from Lewy body dementia. If a person is going to have more than one type of dementias, the most common is a mixture of Alzheimer's disease and vascular dementia. And the reason for that is strokes or a lot of wear and tear on the blood vessels in the brain don't only cause memory loss and cognitive problems, but they actually increase the risk for developing Alzheimer's. And so you can have both conditions. And in fact, pure vascular dementia is quite rare. Most people with vascular dementia also have Alzheimer's disease. So if there's two conditions that are going to co-occur, it's those two. Much less likely, very, very rare, would there be a combination of other types of dementia.
Our geriatrician told us vascular dementia is a terminal disease and gave us typical life expectancies such as 2 to 8 years. Comment?
Mm-hmm. Well, I don't want to comment specifically on any individual patient without knowing their medical history and all the details that the geriatrician has in front of them. But I would say that that would be a very unusual conclusion to land on. And that's because in vascular dementia, unlike Alzheimer's disease, which slowly worsens over time like a rock sort of rolling down a hill, in vascular dementia, there's what we call a stepwise progression. And that means that a person may start out at a certain level, and then after a stroke or a lot of wear and tear on blood vessels, they have a drop in their memory. But then they stabilize for a good period of time until such a time that there's another stroke or another vascular event, and then they're stabilized again. So that would be an unlikely conclusion to draw. But again, keep in mind that many people with vascular dementia also have Alzheimer's disease, which would lead to gradual deterioration over time.
Could I tell a person that he has dementia, or could that worsen the disease?
You know, this is a philosophical question. Is it important for the person with the disease who may or may not have insight about it? Is it important for them to receive the information, be told that they have dementia? All I can say is that from my experience working with tens of thousands of patients, what I have learned is that in most cases, for not just the patient, but family members, people really benefit in the long run from hearing the words and getting specific information. You know, it's not that there's not an emotional reaction or that it's not a very traumatic thing to hear. However, that shouldn't stop us from giving people information. Now, I can tell a patient that they have Alzheimer's disease and maybe they don't care. I've heard that response before, or they're not going to do anything about it. And of course, we all are in control of our own lives until we're too impaired and other people have to step in. So everyone can make their own choice. My personal belief is I think it's important to tell people their diagnosis once. They may forget. If they have Alzheimer's, it's likely they will forget. I don't need to keep talking about it and hammering it over and over again. There's no need to do that. Instead, I can just move forward with the support and resources that I know can help that person.
Well, first of all, mahalo nui loa for incredible information you have shared. I'm working toward my master's degree specializing in gerontology and social work. How can we as social workers help in the cause of dementia?
You know, I think the first thing is advocating that there's training in graduate programs for geriatrics. That varies a lot in social work programs across the country, just like it varies a lot in medical programs or nursing programs around the country. Secondly, as an individual, you can pursue more information because these conditions are just so common. All healthcare professionals really should understand the basics about how to determine what's normal or not. And social workers are well qualified to learn how to administer and score different types of screening tools. And you could embed that in your practice and promote that use depending upon the type of work that you're doing. And so you can be part of the solution. My wife, Michelle, and I actually just produced several videos, training videos for dentists and about dementia and detecting dementia and having conversations with people about concerns about memory loss. And you wouldn't think a dentist would necessarily be talking about something like that. But because dementia is so poorly recognized, any health professional, including a dentist, would benefit from knowing a little bit about these conditions and how to talk to people about brain health. And so we're really excited about those videos to help train a whole new type of healthcare providers. So so glad that you're here as a social worker, and I hope you continue to pursue training in this area.
Dr. Barclay, we're like 3 minutes to 11:30. Can you, there's about, let's see, 4 more questions. Is that okay?
Absolutely.
Oh, great. Thank you. Can you share more about early onset or younger onset and how the course progresses quicker?
Yeah, so young onset Alzheimer's disease is the same disease, same pathology as the condition that affects people at an older age. We have an arbitrary cutoff of 65. If you have memory loss and cognitive symptoms, 65 and older, we call that late onset, and that's the most common. Young onset is memory loss or cognitive changes from Alzheimer's disease that happen at any point before the age of 65. Now, in that context, it's important to know that while it's uncommon, Alzheimer's disease can occur in people in their 30s and 40s and 50s. And we do know that young onset Alzheimer's disease typically, although not always, but often, will progress at a faster rate than people who are older with the same condition. And by that, I mean that over the course of 5 to 7 years, people can be leading fairly independent lives, but in 5 to 7 years have tremendous functional problems that lead them either to need a lot of care or to be placed in an assisted living or nursing, skilled nursing facility where there's more support. Many people with late onset Alzheimer's disease can carry on and live well with the right resources at home for much, much longer. So it's a very arbitrary distinction, young onset versus late onset at the age of 65, but it's the same disease. Unfortunately, a little bit faster course for most people with younger onset. And quickly, I would just say that most older people who develop Alzheimer's disease, it's called sporadic, meaning there's no rhyme or reason that we understand as to why they have gotten the disease. Whereas in younger onset Alzheimer's disease, that's a much more heritable condition. So that tends to run in families and there's a bigger genetic component. But if you look at all Alzheimer's disease together, only 5% of cases are young onset.
Thank you. Could you please repeat the medications for dementia like donazepam? Do they slow down dementia? When should a person with dementia stop taking it?
Yeah, that's a great question. Donepezil or Aricept is probably the most common medication that's used for Alzheimer's disease as a first line treatment. And then there are a few others, namely rivastigmine, which comes in a patch form. All of these drugs act in very similar ways. All they do is make more of a certain chemical that helps memory available to brain cells. So in Alzheimer's disease, the amount of that chemical decreases, the brain has a harder time forming memories, and these medications help to boost up that chemical to support memory. But again, these meds do nothing to slow, alter, or change the brain pathology. The amyloid and the tau pathology continue to develop, which causes people to slowly decline over time. Now, as far as when to start and when to stop, starting any kind of medication, of course, is a personal choice, but often once a diagnosis of Alzheimer's disease is made, for most people, it's an appropriate discussion to talk about whether they want to start one of these drugs. In terms of stopping, the recommendation there is that even though the benefits are typically only for about a year, year and a half, 2 years, we often recommend that if people are tolerating them, They don't have a lot of side effects, in other words, but they stay on the drug until very late in the disease, such that they are need to go to a skilled nursing facility, because at that point there's too much brain pathology that's accumulated and the medications really are not having any impact. The reason we typically recommend waiting until that point to withdraw the drugs is that in some cases, but not all, if you stop the drug too soon, people can have a drop in their function and their cognition and their memory. And then if you say, oh no, let's add that drug back, they do not regain or go back to that prior level of function. And so to avoid that, we typically say stay on the drugs until a skilled nursing facility.
Thank you. What supplements or meds have preventative ingredients for dementia?
That's a great question. There are no supplements that have beneficial effects on memory or dementia, with the exception, again, of in the case of being low or deficient in things like vitamin D and vitamin B12. So a person really, it's not recommended to be on a bunch of supplements unless you're clinically determined to be deficient by a doctor. And that's because there's a lot of false claims out there. You've heard about ginkgo biloba. A more recent one is Prevagen, which comes from jellyfish and has a bunch of claims around it to support memory. The truth is that many of these supplements, when they're put in rigorous research trials, show no effect, and in fact raise your risk of a lot of other problems. 20 years ago, 25 years ago, when I was at UCLA, people were recommending to go on vitamin E because that was thought to be preventive of Alzheimer's disease. And it turned out that high dose vitamin E increased risk for breast and other types of cancers. So you really don't want to be on supplements like that, and you should talk to your doctor about all supplements that you take.
Thank you. Do the medications act more like sedatives or muscle control since they don't stop the brain? I'm not sure what this is a typo. Do you recommend not using them at all? And what is your take on patients who are depressed and want to end their lives or move to a right to die state?
Yeah, so these medications, yeah, they act like a lot of other drugs that don't change the disease. For example, if you have chronic pain and you're taking something over the counter or even a prescription medication, well, that's not targeting typically the underlying cause of the pain. It's simply dulling the symptoms. And, so that's the same as these drugs that are approved for Alzheimer's disease and other dementias. They don't get at the root cause. They simply, slow or dull or weaken the impact of the symptoms. Regarding people with depression, because Alzheimer's disease tinkers with not just thinking skills, but also mood and behavior, depression at some point in the illness or anxiety is not uncommon. Of course, as we mentioned, hearing a diagnosis for the first time can be really hard on people. Right to die is a whole, philosophical debate that this country needs to have. Personally, I do believe that there are certain circumstances in which people should have the right to make those decisions, but it's a lot more complicated when someone may not have their full faculties, when they have memory loss, confusion, dementia. That gets into a much trickier category and is a much harder thing to answer. So the answer is unclear on that one.
Okay. We did have another question added. There are two more questions right now, and please don't type any more questions because we're out of time. But what would cause wear and tear of the brain's vascular health?
Yeah, well, some of that is just simply age. If your blood vessels are 70, 80 years old, over time, they weaken and they break down. And that's especially true of the very small capillary-like vessels in the brain. They wear out. There are also certain health conditions that cause more wear and tear, and one being obese, overweight, smoking, having high blood pressure, high cholesterol, diabetes that's uncontrolled, or drinking too much alcohol. All of those things put a lot of stress and strain on our blood vessels in the whole body, but especially in the brain. And so if you have any one of those conditions or behaviors that are not controlled, it can lead to more vascular wear and tear over time.
Can you speak about the recent research regarding use of water pill or diuretic as treatment for Alzheimer's? Sounds like it's for folks known to have a genetic risk.
I haven't seen anything about that. And because I've got my finger on the pulse of things that are legitimate, I would question that information. It may have been from one study or something that hasn't been replicated. So no, that's not anything that, that I'm aware of is a first line recommendation.
This is our last question. Is B12 helpful? Could a blood test tell whether a person has sufficient B12? I heard that it's not good to take natural supplements if one is taking prescriptive medications. Is that true?
Well, there's, yes, taking B12 supplements or injections sometimes can be helpful, but only if a lab test by a doctor has determined that you are deficient and low. There is too much of a good thing, and high B12 levels can cause a lot of other problems. And so it's not advised to be taking B12 or any other supplement unless you have a diagnosis of some type of deficiency. And, you know, regarding vitamins and over-the-counter supplements and stuff, the research has been very clear about that. Your body actually has a very hard time absorbing a lot of those things. And really, your body is engineered to absorb best from natural food sources. And really, for most of us, instead of supplementing, we should just be trying to eat more healthfully and with a more balanced diet to get the right nutrients. So the answer is too much of a good thing can be harmful. So only take supplements like B12 if you've been diagnosed as deficient, and that's been recommended by a doctor.
Well, that's it, Dr. Barclay. That's all the questions. We're lucky we are not flooded with questions anymore. Thank you so much again. We love you here in Hawaii. We wish that we were here all the time. And thank you all for sticking around to listen to the Q&A, which was brilliant. You are brilliant, and we're sending all of our aloha and love to you in Minnesota right now.
Thank you so much, Jody. And Michelle and I are planning our next trip already back to the island. So.
Oh my gosh, that's great. Thank you so much. That's wonderful news. Well, everybody have a wonderful weekend, and thanks again.
Bye-bye.
Bye-bye.